35 years, female, presented with severe back pain that exacerbated by movement.
الصور مو واضحة كلش.
يعني
regarding the
هاي
spinal.
T1 هاي T1 و T2
واضح كلش.
with contrast. عندي الستار. بعد دكتورة طلع شيء.
نرجع على الساجيتال T1 and T2 and stir.
توستر.
T2 and stir. Multiple sequence, multiple planes MRI of the lumbar spine, showing area of hyper intensity at the lower lumbar region. بس دكتورة خلينا نحدد الليفل. At the L4, L5 intervertebral level, hyper intense disc with hyper intensity notice in T2 and stir of the disc and the end plate. Preserved the height of the this mentioned level intervertebral disc. دكتورة هسه نروح على ال T1 وال T1 post contrast. hyper intense on post contrast. يعني subjectively it is minimally enhanced post contrast. دكتورة هسه أريد الأكزيال ترجعي لي عليه. يعني ممكن كان أكو شي بالأكزيال. يعني this is on T2 there is a hyper intensity is seen in the region of both psoas muscles, more on the left side. It seems hypo on T1 and hyper on T2 with the thin wall multiloculated on the right side. ما عندك دكتورة axial post contrast؟ thin, minimally thin enhancement post contrast notice in both regions of the psoas region. To summarizing these findings and giving a provisional diagnosis, this changes that seen in the lumbar region of edema in the vertebral bone marrow and the hyperintensity in the intervertebral disc with the end plate minimal enhancement, preservation of the height of the intervertebral disc, presence of these two obvious collections in the psoas muscle. A picture of these changes might be due to infectious cause in the lumbar region. infectious spondylodiscitis. The presence of thin wall collection with minimal thin enhancement, uniform thin enhancement, and preservation of the intervertebral disc, pointing to the TB spondylodiscitis.
فإذا
تسمعني أستاذ؟
أسمعك شيء. فإذا هسه أنت وصلتي إلى نتيجة أنه هذا بوست ديزيز، مو صحيح؟
أي نعم أستاذ.
قلتي which level؟
L4 L5.
Is it the common site of
أستاذ بصراحة لا, it is not the common site. Commonly the post disease is presented in the thoracic intervertebral disc. presentation يعني striking feature مالته إنه يكون أكو deformity in the spine
مو صحيح؟
اللي هي قبض
زين
deformity.
لعد ليش أنت حددتي إنه هذا تي بي according to what؟
The preserved height of the intervertebral disc with thin wall enhancement in the paravertebral muscles. هو هذا يعني الثاني يعني خلاني أقول تي بي rather than biogenic. هو صح ال يعني level هو not common, بس هي هاي يعني إنه preserved height and the thin wall collection and the thin enhancement of the collection يعني there is no obvious يعني إيه هو هذا اللي خلاني أقول إنه هذا تي بي rather than biogenic.
يعني أعتقد إنه واحد يخليها infectious better than يعني specify إنه this is tuberculosis أو biogenic أو بروسيلا. يعني أنا بالنسبة لي أقول أفضل لأنه أوضح لك شو اسمه بالفيتشرز مالت الانفكشوس، مو صحيح؟
أي
زين
نعم صح.
يعني التي بي مثلا be a healing and destructive processes sometimes it's a calcification والسايت والهذه ف يعني واحد يعتمد على البايوبسي او السبيسيمن مالت الاسبريشن يكون افضل من ينطي دايجنوسيس وهذه. بعدين حتى اي ديفورميتي اي كولابس للفرتبرا ماكو زين.
نعم.
وسمتايمز الايرلي بايوجينيك او البروسيلا همينة تنطي هالشكل يعني. على كل اوكي شكرا دكتوره مريم. دكتوره رنين رفعت ويانا.
نعم أستاذ، صباح الخير.
صباح الخير. your opinion رنين.
مثل ما تفضلت زميلتي، يعني أكو عندنا يعني at the level of L4 L5 vertebral disc intervertebral disc there is abnormal signal intensity in form of hypo in T1, hyper in T2 with the minimal enhancement post contrast, and also there is evidence of bilateral paravertebral يعني fluid collection with minimal peripheral enhancement يعني goes with يعني paravertebral abscesses. يعني هو صراحة هي تجي يعني ويا spondylodiscitis، بس لأنه هي من preserved الديسك سبيس ويعني ما صاير عندنا destruction للديسك، ف يعني هي يعني in general هي spondylodiscitis يعني involving both vertebral bodies اللي هي L4 L5 والintervertebral disc in between. ف يعني نفس إنه تكون يعني هي infectious و كذلك إنه هي ال signal intensity of the vertebral يعني bodies يعني ممكن همنا نستبعد إنه هي ممكن إنه metastatic يعني involvement، يعني هي تكون يعني involvement of the disc، فممكن نمشي ويا ال infectious rather than إنه ممكن إذا metastatic.
اوكي رنين شكرا جزيلا. نرجع على دكتورة أمينة.
نعم أستاذ. هي الكيس أصلا known case of TB presented with back pain. There is a multi-level of abnormal signal intensity with disc space preservation and bilateral large psoas abscess that is thin wall. So the diagnosis was TB spondylodiscitis. Our presentation today is the tuberculous spondylodiscitis. I am Dr. Mina Mazen, second grade Iraqi board. هذا الريبورت مالتنا كان. Also known as a pod disease, referred to vertebral body osteomyelitis and intervertebral discitis from tuberculosis, can lead to kyphotic deformity and mechanical instability. TB is one of the most common infections of the spine in countries where TB is prevalent. 15% of patients with TB will have extrapulmonary involvement. Discitis or osteomyelitis comprise 50% of manifestation of musculoskeletal tuberculosis, usually affect the lower thoracic and upper lumbar level of the spine. A history of tuberculosis, a positive skin test, and elevated erythrocyte ASR may be useful in the diagnosis of spinal TB. Despite the advance in imaging modalities, the time between the initial onset of symptoms to the time of diagnosis range between 4 and 6 months. A delay in diagnosis is the factor that most contribute to worse prognosis with an increased likelihood of surgical treatment and neurological deficit. Clinical presentation usually with back pain, lower limb weakness or paraplegia, kyphotic deformity, and constitutional symptoms like fever and weight loss. Etiology in early infection begin in the metaphysis of vertebral body, spread under the anterior longitudinal ligament, lead to multi-level involvement and skip lesions. Paraspinal abscess formation can be quite large, initially doesn't involve the disc space. In chronic, severe kyphosis result. Infection is often diagnosed late. There is much more severe kyphosis in granulomatous spinal infection than pyogenic infection. This is case with Gibas deformity and spinal cord impingement. Here we see there is T7 pedicle destruction and lateral displacement of the paraspinal line indicate there is a paraspinal collection. In CT, we see there is breast diffraction and paraspinal mass. In MRI, there is abnormal signal intensity in T7 and T6 with epidural extension causing spinal cord impingement or stenosis. The spinal is involved due to hematogenous spread. There is anterior involvement, central and posterior. The anterior involvement in adults, particularly in older individuals, the disc space usually spare from vascularity. So it is involved late, while in younger individuals, especially in children, it's involved early in the disease. Infection then spread under the longitudinal ligament and infect the adjacent vertebra. Gradual anterior collapse typically result in acute kyphotic or gibbous deformity. The central involvement is the most common, represent 98% of all spinal TB, spread via venous plexus of Patterson in older age group usually, will lead to gradual collapse like vertebra plana and kyphotic deformity and can lead to cord compression. While the posterior involvement due to venous hematogenous spread via posterior venous plexus, posterior involvement follows similar pathogenesis to anterior involvement, yet utilizes the posterior longitudinal ligament and often involve the neural arch. Cold abscess is in late stage spinal tuberculosis, usually large, without any severe pain or frank pus or any inflammatory sign. An plane radiograph can be difficult to detect in early stage because of the preservation of disc space. There is a reduction in vertebral height, irregularity of the anterior superior anteplate, and subligamentous extension. There may be some irregularity of the anterior vertebral margin. This is classical and with TB spondylitis. Here we see destruction of the vertebral body and loss of disk space, and there is destruction of disk space, cubic deformity. Later can be a large collection, and ivory vertebra can result gibbous deformity and vertebra plana. As with other extrapulmonary TB, a plain chest radiograph is often unremarkable. No pulmonary lesion seen in up to 50% of cases, with the source being primary lung lesion that is clinically silent. Here we see disc height loss, vertebral collapse, and spinal deformity. In CT, we see the extent of involvement and the presence of epidural component or cord compression. Here a case where there is disc space loss, inferior end plate and superior end plate destruction, and epidural and paraspinal abscess formation and cord compression. In MRI, in T1 is hypointense, T2 hyperintense, and there is enhancement. Here is case, there is T11-12 destruction with end plate irregularity, paraspinal involvement, and compression on the spinal cord, and kyphotic deformity. There is enhancement of vertebral body. The disc space is preserved, mildly preserved, and there is cord compression. Here is multi-level involvement and bilateral psoas abscess formation. That's thin wall. In the differential diagnosis, first of all, there is the infection, which is pyogenic spondylitis. Intraspinal abscess, usually absent in pyogenic spondylitis, while in tuberculosis is present. الwall يكون thick and irregular, not thin. الvertebral body enhancement عادة homogeneous, هنا heterogeneous. عادة أقل من 2 vertebral bodies، هنا multiple body involvement. Disc preservation يكون moderate to complete destruction، هنا normal to mild disc destruction. Other differential diagnosis: brucellosis, fungal infection, and sarcoidosis, and metastasis. And the treatment, if early diagnosed and there is no neurological deficit, anti-tuberculosis antibiotic given, while if there is neurological defect, progressive kyphosis or mechanical instability, surgical management. 4 types of surgery we have: posterior decompression and bone graft, anterior decompression and fusion and with bone autograft, or anterior debridement followed by posterior fusion with instrumentation, or posterior fusion with instrumentation followed by anterior decompression. The prognosis, usually if early diagnosed and there is no neurological deficit, good prognosis, while if there is no response to medical treatment or damage to the spine, the prognosis may be fatal. Thank you.
شكرا جزيلا.